Hi, we are from Group 6. Today we are going to present a workshop case study. Jack, who was involved in a traffic accident and was urgently transfused with ABRH plus blood based on the information on his blood group card. Soon after the transfusion started, he experienced a sudden drop in blood pressure and difficulty breathing. This sign prompted several initial hypotheses, including an acute hemolytic transfusion reaction (AHTR), where performed antibodies attack incompatible donor red blood cell. Other possibilities included an anaphylactic reaction causing rapid difficulty breathing or a septic transfusion reaction from bacterial contamination. However, the lab finding revealed that Jack's actual blood group was BRH plus and his history revealed a bone marrow transplant 6 months earlier. Considering this finding, the most possible final diagnosis is a HTR triggered when his antibody attacked incompatible antigen on the donor ABRH plus red blood cell, causing major ABO incompatibility.
Genetically, Jack's blood group is determined by the ABO and Rh genes he inherited from his parents. For a B blood type, the possible genotypes are either B, or B and O, and for Rh positive, the genotype can be B, or D and simple D. This means Jack's true genetic blood group is BRH+, and importantly, this genotype does not change even if he receives a transfusion. However, because Jack had a bone marrow transplant 6 months ago, his blood group card may have been based on donor-derived cells. So genetically he is B+, but his older card stated AB+, which contributed to the confusion. Hematologically, what matters during transfusion is the phenotype, essentially the antigens that are actually expressed on the surface of the red blood cells. Before transfusion, Jack's phenotype was B positive, meaning his RBCs express antigens and RHD antigen, and his immune system naturally produces anti-A antibodies. During transfusion, he was given AB-Rh plus blood, which carries both AB antigens. This creates a phenotype mismatch. His anti-A antibodies will immediately recognize the A antigen on the AB blood as foreign. This triggers complement activation and leads to rapid hemolysis.
Jack originally had an AB positive blood group, but after his bone marrow transplant, his blood type changed to a B positive. This happens because the bone marrow controls what type of red blood cells we produce in our body. Therefore, after the transplant, his immune system now behaves like a B positive individual, meaning he can naturally produce IgM antibodies against the A antigens. When he was accidentally given AB positive blood, his immune system recognized the A antigens on the donor's red blood cells as a foreign antigen. His anti-A IgM antibodies immediately bound to the A markers on these transfused RBCs. Once IgM antibodies are bound, its Fc region changes shape, allowing C1q to bind, which activates the C1 complex and triggers the complement cascade, forming C3 convertase. The cascade continued as C3 convertase cleaves C5 into C5a and C5b. C5b then combined with C6, C7, C8, and C9 to form the membrane attacks complex, or MAC. This MAC created holes in the transfused RBCs, causing intravascular hemolysis. As the cells burst, they release large amounts of free hemoglobin, which can lead to shock and kidney damage, explaining the severe transfusion reaction.
Next is phase 3, which is the inflammatory response. In Jack's case, as the transfused red blood cells were destroyed, a cascade of inflammatory mediators was released into his circulation. Pro-inflammatory cytokines including IL-1, 6, 8, and tumor necrosis factor alpha were secreted by activated immune cells responding to the antigen-antibody complexes. Simultaneously, the complement fragments C3a and C5a, known as anaphylatoxins, were generated from the complement cascade and began circulating in Jack's bloodstream, where mast cells and basophils are stimulated to degranulate and release large amounts of histamine. Additionally, the kinase system was also activated, leading to the production of bradykinin, which is a potent vasodilator. The combined effects of these inflammatory mediators produced the clinical symptoms that Jack experienced. The bradykinin, histamine, and cytokines caused Jack's blood vessels to widen significantly, resulting in the drop in blood pressure that was observed. This hypotension was further exacerbated by increased vascular permeability, which allowed fluid to leak from his blood vessels into the surrounding tissues, reducing his circulating blood volume. Concurrently, the histamine and other mediators narrowed Jack's airways and led to breathing difficulties he experienced. This inflammatory storm explains why Jack's condition deteriorated so rapidly after receiving the incompatible blood transfusion.
In pathology, acute hemolytic transfusion reactions begin with early systemic symptoms such as fever, sudden hypotension, and possible shock. Respiratory signs may include dyspnea or bronchospasm. Renal involvement is marked by back or flank pain, hemoglobinuria, and in severe cases, oliguria progressing to anuria. Patients may also report chest or loin pain or burning at the infusion site. And finally, coagulation issues, which includes bleeding from IV sites. The first major consequence is intravascular hemolysis, which causes massive red blood cell destruction with hemoglobinemia, hemoglobinuria, and acute kidney injury. That may progress to acute tubular necrosis. The second is severe hypertension from cytokine release, vasodilation, and renal failure, which can lead to multiple organ dysfunction. Another major complication is disseminated intravascular coagulation caused by red blood cell debris, which leads to prolonged bleeding, microthromby, and multi-organ failure. Cardiovascular issues such as arrhythmias or cardiac arrest may result from hyperkalemia. Severe cases, especially with delayed transfusion cessation, high transfusion volume, or significant ABO mismatch, can be fatal.
Now let's talk about the causes. This case was caused by two main factors: ABO incompatibility, as mentioned before, and outdated blood group information. His blood group card stated AB, even though his blood type had changed to B after a bone marrow transplant, which happened 6 months earlier. This mismatch led to the wrong blood being transfused. Now let's talk about some of the treatments. These involve stopping the transfusion immediately, maintaining the IV line with normal saline, and stabilizing the patient with diuretics, aggressive IV fluids, urine monitoring, and oxygen supply if needed. And now for the preventions. Preventions rely on proper antibody screening and cross-matching, reviewing patient history, especially post-transplant changes.
In conclusion, Jack experienced an AHTR because the ABRH plus blood he received was incompatible with his current BRH plus type after his bone marrow transplant. His anti-IgM antibodies rapidly activated the complement pathway, causing intravascular hemolysis and severe hypotension. This case highlights the importance of strict preventive measures such as verifying updated blood types in post-transplant patients and providing immediate treatment to prevent fatal outcomes. That's all from us. Thank you.